Hi everyone, I'm Taeyun Kim, working at Korea National Cancer Center. And first of all, it's a big honor for me to get a chance to be a speaker of the 9th ARTS meeting. As you all know, proton therapy has played an important role as one of the most advanced radiation treatment modality in recent years. And the excellence of the proton therapy has also been reported from many research papers. And for this reason, proton therapy getting a lot of interest in many other sites. And today, I'm going to talk about the various roles of the proton therapy, more specifically for clinical perspective. And here is the outline of my presentation today. I'll be giving a brief explanation about the proton treatment techniques in proton, and we'll focus more on how proton therapy is playing a key role for each treatment site. And well, before we begin, let me briefly introduce Korea National Cancer Center. And shortly, KNCC was established in 2001 as the first cancer hospital in Korea. And it is located in Goyang City, Gyeonggi Province. And KNCC also introduced the proton therapy system for the first time in Korea back in 2007. And other than proton therapy, KNCC also has 3 linear accelerators and 2 tomotherapies, and many other treatment options. And this is the layout of KNCC proton facility. And there are 3 main components: beam production part, and the beam transport line, and beam application. And the first is cyclotron, which is the key part of this whole system, and that produces proton energy up to 230 megavoltage. And right next to it, there's a degrader is placed to change the energy level from 70 to 230 megavoltage according to the tumor depths. And once the proton beam gets ready, it is delivered through beam transport line, which is connected to each treatment room. And KNCC basically has 3 rooms. The one fixed beam treatment room, usually for eye tumors, and the other 2 gantry treatment for the rest of the patient. In proton therapy, it is very important to understand about the proton beam delivery technique, as it helps to achieve better outcomes for treatment in clinic. And there are 2 different modes in proton: passive scattering and scanning mode. In passive scattering mode, it uses a physical device called scatterer to get a larger field size. And depending on the number of scatterer, it is classified into single scattering mode and double scattering mode. And in this passive mode, there are a number of components are needed, such as range modulator wheel, and block aperture, and range compensator for shaping proton beam distally. And these are the source of the neutron dose that can damage to patient or the radiation therapist. And in scanning mode, however, there's no need to have such a physical device to get a treatment field, because a scanning magnet can control the proton beam in all directions. And one of the most advanced delivery technique is passive beam scanning mode. So as you can see in this video, the PBS can deliver proton beam with tiny spots onto the layer that covers the target volume, and which can provide a better dose distribution over PBS, over passive mode. And this again can be classified into SF4, shortly single field optimization, and MF4, which stands for the multi-field optimization by its optimization method. And especially the PBS is more sensitive to the organ motion, so the management of the interplay effect is very important. And this table summarizes the characteristic of each delivery technique. As you can see, the red ones, the maximum range and available field size and the lateral penumbra are different according to each delivery mode. And considering the benefit of it, it is also very important to choose an appropriate delivery technique for the purpose of the treatment. Early days of proton therapy, the majority of the patients who received the proton therapy were prostate cancer. And that was because the prostate is a small-sized target and located in the center of the body. So the characteristic of the proton therapy could be best applied. And however, as a proton therapy technique has advanced, and the treatment of other sites using proton therapy has gradually increased over time. And since 2013, as you can see in this graph, the rate has overtaken the prostate cancer. And the diagram on the left side summarizes the research results up to 2021 related to the proton therapy for various sites. For hepatocellular carcinoma and the chordoma and lung and prostate cancer, it was reported that the overall survival was increased with proton therapy. And for the head and neck and esophageal cancer and prostate, the study results showing that the proton therapy significantly lowered the side effects and the radiation toxicity compared with an X-ray treatment. Now, however, the sufficient data are still needed to prove the effectiveness of the proton therapy. So there's a lot of clinical studies are currently underway. So now let me share with you the various role of proton therapy for each site based on KNCC experience. And this is the statistics of the patients who received the proton therapy at KNCC from March 2007 and February 2022. And liver and pancreatic cancer account for the largest portion. And we also mainly treat the prostate and lung and pediatric patients with the proton therapy. As mentioned earlier, the prostate cancer is the most suitable case for proton therapy. And normally, prostate cancer patient is treated with two lateral field with rectal ballooning. And in order to reduce the rectal dose more effectively, a treatment plan is created using single field optimization technique, considering the robustness. And the bottom image are showing that the difference, dose distribution with various modality, the 3D CRT and IMRT, and the tomotherapy and proton. And the study reported that the PBS with SFO technique delivered the lowest dose to the rectum and the bladder to compare with the other modality. And for PSA change, another study reported that the PSA value over time since proton therapy continued to decrease even after more than 37 months. And compared with an MRT, many papers reported that there was no big difference between the proton and the X-ray treatments. But in terms of side effect, proton has an advantage. A paper published from Japanese proton group reported that the proton is more favorable option to a high-risk cases in terms of a overall survivor, as you can see in this graph. And for the side effects, and the proton shows a similar GI toxicity to that of an IMRT, but less GU toxicity over X-ray treatment. And this is because the rectal bleeding is more related to the higher dose reason, but GU is more associated with a wider range of the doses to the bladder, which well describes the benefit of the proton therapy. And brain is a good indication for proton therapy, and especially for pediatric patients. And three-field with a non-coplanar beam setup is mainly used if the target is close to a critical organ, such as the brainstem. And in case that the brainstem is right behind the target, we put at least one beam from vertex side so that we can avoid the risk of the ending Bragg peak near the brainstem distally. And the PBS with MFO technique is the first option for brain tumor since it can help us to get the better dose distribution, and particularly in the scalp region. And the key role of the proton therapy for brain tumor is actually reduce dose to a brain substructures associated with memory and thinking functions. And a research presented at the ISTRO conference shows that the PBS proton therapy delivers the lowest dose to the temporal lobe and hippocampus, so offering the best hope of preserving the cognitive function. In a paper published in the Journal of Neuro-Oncology in 2019, presented the data from analysis of neuropsychological outcomes of 125 pediatric cancer patients who received the proton and an X-ray treatment. As shown on the table on the right side, so you can see the overall IQ evaluation of the proton was about 7% higher than that of an X-ray. In particular, the process speed and the word reading and the written calculation ability also show the higher result compared to the X-ray. And this is very meaningful finding that supports the result of the previous proton therapy studies. Another good application for proton therapy is spinal irradiation. And because no radiation dose is delivered beyond the target in proton therapy, so significant side effects from radiation therapy actually can be reduced very effectively. And the symptoms like vomiting or nausea, which frequently occur during radiation treatments, are also very well managed in proton therapy. And KNCC in particularly is to treat the patient in a way that they reduce the dose stiffness in the field junction between the brain and the spine, and it also can reduce the set of uncertainty by the partially overlapping the brain and spine region on purpose. And on the bottom right image is showing that the dose profile at the field junction so become very smooth and flat with the MFO perturbation optimization and overlapping fields. So these are the two fields that comes from brain and comes from the spine, and make the two fields eventually make the beam very smooth. And here's the image that how we set up the beam arrangement for the CSI. And the head and neck cancer can also take advantage of proton therapy as there are many complex organs are located near the target. And the number of proton cases for head and neck is also increasing year by year. And typically, three fields are used from PA, RAO, and LAO. And the plan is created with MFO technique, and CBCT is required to check if there's any changes in the beam path. If needed, adaptive plan is immediately applied. And the benefit of the proton therapy for head and neck is actually to improve the quality of life for the patients. And for the results, for the benefit of the head and neck proton therapy, there are many studies that have been reported that the proton therapy can reduce the use of feeding tube for head and neck patients after treatment. And recently, the UPenn Proton Center reported that the proton can significantly reduce the mild severe appetite change and the moderate severe xerostomia compared to an X-ray treatment. But for the conformality of the plan, compared to VMAT and tomotherapy, the proton therapy for head and neck is somewhat less conformal. That's because the fewer field and the limitation of the beam delivery option. And to compensate for this insufficient aspect of the proton therapy for dose conformality, a new research about proton arc therapy is now actively being conducted at the Berman Proton Therapy Group in the United States. And actually, the current proton therapy machine cannot use a large number of beams due to limitation of the delivery technique and optimization for in the planning stage. But in this study, they are trying to improve it by introducing a different concept of a new control point. So it is expected that a more advanced proton technique will be applied in the near future. We're also treating the lung cancer with the proton therapy based on SBRT regimen. And for lung cancer, normally we use a 3 to 4 beams, but mostly use 4 beams. And in case of the lung tumor, the scattering method is basically used because of the organ motion due to the respiration. And each of the 4 beams needs to be separate enough so as to have no overlapping part. And the 40 CT taken for gating proton therapy to minimize the dose to normal tissues. And the image below is the treatment plan for lung cancer that performed at KNCC. And we use evaluation table from the RTOG protocol the 1021. And the key role of the proton therapy for lung cancer is to reduce the doses to the critical organs, such as including the lung and heart and esophagus and spinal cord. And the PTCOG, the Particle Therapy Cooperative Group, addressed from their report that the larger tumors located either centrally or close to the brachial plexus may benefit more strongly from proton therapy. And last December, KNCC published a planning study with 42 cases of stage 1 lung cancer patients. And in this study, the 3D CRT and IMRT VMAT and proton therapy were compared. As shown in the graph on the bottom right, the blue bar indicates the proton therapy. And as you can see, the significant dose difference were reported in the mean lung dose and the lung V5 and the mean heart dose and the heart V5. And this is images how we treat the patient, how we treat the lung cancer patient with the proton. And esophageal cancer also can be a good indication for proton therapy. And in KNCC, by analyzing the pattern of failure based on a paper published last year, we treat the extended field proton therapy, which includes the entire esophagus, and later we're going to put the boosted field for the local region of the target. And for this treatment, PBS that affords larger field size actually plays an important role to reduce the dose to the normal tissues. And the graph on the right side here shows that the proton therapy seen as yellow could reduce the mean lung dose and the mean heart dose, as well as the volume irradiated by the proton therapy of the two organs is significantly reduced compared to other modalities. As seen from the statistics in the previous slide, liver and pancreatic cancer are the most common case in our institution. And the three-field with SIB, simultaneous integrated boost technique, is mainly used, and single or double scattering mode is applied due to organ motion. And all patients are treated with hypofractionation regimen of 60 to 70 grade in 10 fraction. And gating treatment is mandatory for all liver and pancreatic cancer patients. Not only small-sized tumor, but proton can also be applied to a larger tumor case. And here is the round couch that is a homemade device, which allows us to put the proton beam from the posterior side like this, and not concerning about the edge effect. And many studies about proton therapy for liver and pancreatic cancer have been published for many years in our institution. And the overall survival was reported that it was pretty improved compared to a conventional treatments. And for the toxicity, the grade 2 or higher was rarely reported. So the safety of the proton therapy has been confirmed in many ways. And last year, KNCC published a paper in the Journal of Hepatology about the phase 3 randomized clinical trial that compares the proton therapy and radiofrequency ablation, shortly for RFA, for hepatocellular carcinoma. And that was the first the phase 3 randomized clinical trial to evaluate proton therapy versus RFA in recurrent NCCC. And the study concluded that the proton therapy was non-inferior to RFA in terms of local progression-free survival and safety. And this was very meaningful finding as it verified the safety and efficacy of the proton therapy for HCC for the first time. And here is the summary of my talk. Compared to the conventional radiation treatment using photon beams, proton therapy reduces the dose to the normal tissues and delivers the radiation dose more intensively to the targets, which can improve the patient's quality of life and reduce the side effects more effectively. And in order to maximize the effect of the proton therapy, it is important to understand the beam delivery technique and apply appropriate technique to the treatment site. So in the future, more various studies are needed to prove the effectiveness of the proton therapy, and it is expected that the role of proton therapy will further increase by the introduction of more advanced treatment technologies. Thank you for your attention.